as well as the National Cancer Control. And currently, he was trained in UK, and then currently he's leading the oncology department at the RCD American Oncology Institute Cancer Center. And he had done many pioneering work, especially the public cancer screening, as well as he has vast experience in this palliative care, especially the community palliative care, and he does a lot of palliative care work at RCD Hospital. So I think today we have a very good person, very good resource person, and consultant that who is going to present us the topic. Uh, on this navigating the gray areas. I think this is something very much needed, especially when we're looking at the terminal care. So over to you, Dr. Gunatilaka.
Thank you very much. Thank you very much for inviting me for this session. I think this may be the second webinar that I am doing with the College of Palliative Care, Palliative Medicine. So thank you very much for this opportunity. So today's topic is navigating the gray area, ethics, compassion, and advanced technology in terminal care. In this session, the objectives are introduction, terminal phase and terminal care, recognizing the terminal phase, the consequences of missed terminal diagnosis, benefits of correctly diagnosis of dying, ethical principles of in terminal care, compassion in terminal care, what we do, advanced technology in terminal care, and terminal discharge. So as clinicians, we are trained extensively on how to save lives. But how many hours have we spent learning how to help someone dying? Today, we are going to talk about the one medical certainty that awaits 100% of our patients. When medicine can no longer add days to a person's life, that is when the life asking death, our job shifts to adding life to their remaining days. It immediately highlights a major gap in traditional medical education and flips the definition of healthcare success from just survival to dignity. The terminal care is not the admission of defeat. It is the graduation from curative medicine into comfort medicine, which is at a higher level. When a patient reaches the terminal stage, we do not stop treating them. Instead, we aggressively treat their pain, their anxiety, their breathlessness, and their fear. We step in when the laboratory tests stop mattering and the patient's comfort matters most. It addresses the subconscious bias or moral distress some healthcare workers feel when transitioning a patient away from curative interventions. The famous physician, Dr. Edward Livingston, once said, "The role of medicine is to cure sometimes, to relieve often, to comfort always." In modern medicine, we have become incredibly good at the first part, that is, cure sometimes. But in this lecture, we are going to master the final two, relieving often and comforting always. It provides historical, ethical weight to the topic and reminds the audience of the foundational purpose of healthcare. What is terminal phase? The terminal phase is defined as the period when day-to-day deterioration, particularly of strength, appetite, and awareness. So this is not monthly deterioration. This is not weekly deterioration. This is the deterioration the loving ones from the family or the healthcare team or the carer notice in the patient that day-to-day the deterioration is occurring. So that time we call the patient is in the terminal phase of their trajectory, disease trajectory. Now, terminal care that ensures the patient's comfort physically, emotionally, and spiritually. Make the terminal part of the life peaceful and maintain dignity. Now, make the memory of the dying process as positive as possible for those left behind by care and support given to the dying patient and the family. So, if you are able to give a good quality terminal care, the people who left behind, the loving ones of the dying patient, even after several months, several years, they can go back to the event and they can be at least be peaceful about the how it has ended, how the loving family members' life has ended, which is a peaceful way. So if this happens in a very bad way, again the other way around also can happen. That will be a disastrous thing. Now, recognizing the terminal phase, this is very important. This is where our clinical staff or the healthcare staff make a lot of mistakes. Now, diagnosing an irreversibly dying patient over the last days of life, this is one of the most complex responsibilities in medicine. There is no single diagnostic test it relies on. To diagnose this phase correctly, clinicians must follow a strict three-tier assessment protocol. Step 1, establish the clinical context. Step 2, identify the cluster of physical signs. Step 3, implement the two-clinician and multidisciplinary review. Step 1, establish the clinical context. Now, before looking at physical signs, you must confirm that the patient is a candidate for the dying phase. A clinical diagnosis of dying requires two absolute prerequisites. First one is advanced irreversible pathology. The patient must have an established progressive life-limiting illness. For example, end-stage malignancy, severe multi-organ failure like chronic end-stage renal failure, chronic end-stage heart failure, chronic obstructive pulmonary disease, right, like that, or advanced priority. So these are few examples. The second one is exclusion of reversible causes for this deterioration. So even daily basis deterioration can occur due to reversible causes. So we should keep that in mind. So you must systematically review and rule out treatable conditions that could mimic the dying phase. These include acute infections, sepsis, severe biochemical or metabolic imbalances. Example, hypercalcemia, profound dehydration. And opioid toxicity or acute urinary retention, impaction, fecal impaction causing delirium. So we need to consider those things. Now, step 2 is identifying the cluster of physical signs. Never rely on a single physical sign. A correct diagnosis is made when a progressive cluster of signs presents simultaneously over days or hours. Now, profound functional decline. The patient is completely bedbound, exhibit extreme weakness, and sleeps for a vast majority of the day. So this is WHO performance status 4. So loss of oral intake. The patient has a profound lack of interest in food and fluids and loses the physiological ability to swallow medication and liquid safely. The third one, neurological changes. Progressive deterioration to semi-conscious. Some patients may experience terminal delirium and perfusion failures, shifting of blood flow away from the extremities to vital organs. This manifests as profound cold hands and feet, reminding us the childhood teledrama Hatpana. A weakening peripheral pulse, and peripheral cyanosis or skin mottling. Livido reticularis, starting at the knees. The other one is altered respiratory pattern, the onset of irregular breathing. This includes periods of apnea, rapid shallow breathing, or chain stroke respiration, alternate apnea and hyperventilation. The other one is the terminal secretions. Loss of the swallow and cough reflex leads to the pooling of respiratory secretions in the hypopharynx, causing a distinct noisy breathing pattern, historically known as the death rattle. Now, the step 3, implement the two clinician and multidisciplinary review. Because of the profound ethical and practical implications of this diagnosis, such as withdrawing curative interventions, modern guidelines like the NICE guidelines on care of dying adults recommended a consensus approach. First one is multidisciplinary assessment. Incorporate the insights of the bedside nursing staff who observe the hour-by-hour trajectory of this patient. The second one is senior consensus. The assessment should ideally be validated by a senior clinician or a specialist in palliative medicine to prevent premature closure of this patient's curative management or life-prolonging management. Continuous re-evaluation. If there is any clinical uncertainty, the patient must be managed with a plan that is reviewed at minimum every 24 hours. Now, for example, a sepsis can mimic a irreversibly dying picture. So you might have to give a trial of antibiotics and observe this patient very closely. Now, this allows the team to pivot immediately if the patient stabilizes or demonstrates a temporary unexpected recovery. So if patient is getting better, so then we can switch to the life prolongation treatment without continuing the, without considering the terminal care. So that is very important because we should not give terminal care to any patient with a reversible deterioration, right? So if it can be reversed, we should reverse it because we cannot hasten death. Now, according to Ferris et al., there are two roads of death. One is the usual road, the other one is the difficult road. Now, the usual road, it starts with a normal performance, then patient becomes sleepy, lethargic, obtunded, semi-comatose, and comatose, and at the end of the trajectory, end up with death. The difficult road, from the normal performance status, patient transfer to restless behavior, then become confused, tremulous, and he might get hallucinations, myoclonic jerks, seizures, and then semi-comatose and comatose, and at the end ended up in death. So these are two roads to death project proposed by Ferris et al., observed by him. Now, critical clinical pitfalls to avoid in the terminal diagnosing terminal patient. The dehydration myth. Now, do not confuse a dying patient's natural lack of thirst with standard treatable dehydration. Now, forcing intravenous fluid into an actively dying patient often overloads their failing cardiovascular system, causing fluid accumulation in the lungs that lead to pulmonary edema and worsening breathlessness. Actually, this is happening in most of the clinical situation. When a patient is bad, when the clinical staff sees the patient, the traditional way of treating this patient is putting a cannula, IV cannula, and set up an IV drip and give fluids, which actually hasten the death, which is not acceptable. The second one is the diagnostic delay. Delaying the diagnosis of dying while waiting for absolute certainty or diagnostic lab tests prolongs unnecessary invasive interventions and delays the initiation of essential anticipatory comfort medications. So what will happen if you delay the diagnosis of the dying process? So there will be a lot of unnecessary things, because sometimes as a clinician, you are I mean, if you are not an experienced person in this field, the diagnosis of dying process might be delayed. So what will happen is prolonged unnecessary futile interventions will happen for this patient. So the main consequences of a missed terminal diagnosis. So if you don't diagnose the terminal phase, what will happen? Failing to recognize or diagnose the terminal situation of a dying patient can lead to severe physical suffering, prolonged emotional distress, and a loss of personal dignity during their final days. Now, this can happen from the clinical staff, this can happen from the patient side, this can happen from patients' family members, and even the caregiver. This can happen from any one of these entities. So, for example, a few years back, I had a patient, elderly patient. She was between 70s and 80s. She was a retired teacher, very nice lady. She came to us with metastatic pancreatic cancer. So everywhere in her body, liver, lung, most of the places are full of metastatic deposits. So she was admitted. Her children were not in the country. She had two children, one daughter and one son. Son was in Australia, and daughter was in Canada. So initially, son contacted me over the phone, and the first thing he asked me was, "Doctor, I know she's having metastatic pancreatic cancer. What do you think? How long she's going to live?" Then, I mean, this was a more over the phone conversation. So usually this is the worst communication method in this sort of situation. So I asked him, "What do you think?" Then he said, "Doctor, I have done internet search, Google search, and I know this is very bad." So I said, "No one can tell the exact timeline, but what you are correct, she's not having a long period." So he decided to come soon, very soon, and he has read about this clinical situation and what should be done and what should not be done. And he agreed for palliative care. So we knew that very soon she will enter into the palliative, the terminal part of her life. So now at that moment she was talking, she was taking a little bit of oral feeds. She can walk with help. So her husband was with him. So son came, and son discussed with me and told, "Okay, what I need is keep her comfortable." And he has read about palliative care. So we were arranging everything. So the spiritual care, the social care, the pain management was arranged. So we were giving morphine. Her pain was settled with that, and she was listening to Pirit, and her bed was surrounded with a lot of flowers. Right, a lot of things are happening. So her daughter called us, and she got to know that she was on morphine and these things are happening. But strangely, she was telling, "My mother is given only morphine. Are you giving only morphine? You are not doing any investigations." So I said, "Okay." Uh, then we had a discussion, but she was a bit arrogant. I mean, this type of thing can happen when children are away from their parents and they haven't had a chance to be with them, and they knew that subconsciously they knew that she knew that mother is leaving now. So she has to compensate. So she wanted to do everything within a short period. So she came and she was changing all the management. So very difficult to convince her. Even her brother was unable to convince her. So then she got second opinion from other clinicians. Unfortunately, they were doing whatever she's telling. So she was undergoing PET CT scans. She was transferred to the ICU. So what has happened? She lost her personal dignity. How? She started blackguarding all the staff members in filthy words. So she got delirium and she was shouting, she was removing her clothes, she has lost her dignity by transferring her into the ICU. So generally we call this in general terms this is ICU delirium. So I closely I talked to the daughter and said, can you see your mother is losing her dignity? So after transferring to the ICU, oh, that's okay, she's in ICU. So she was talking to me like that. So now there are a lot of conflicts building up. Her brother and herself are not in the same decision. So ultimately, the brother decided, okay, I'm leaving. So let my sister manage my mother because I know I can't change her mind. So what she decided, she wanted to keep her in the ICU throughout, and she wanted to do all the tests, and she wanted to know whether she can give her mother can get chemotherapy, so all these treatments. And the other clinicians were actually trying to do those things, and she ended up in a horrible death. Her legs become necros, and ultimately I had to withdraw from the management because um, my input was not accepted. So that unfortunate ladies ended up her life in an agony. So that was a bad death. So you can understand missing the terminal diagnosis, how it can change, because she was experiencing good terminal care and suddenly change into curative pathway inappropriately and had a very bad death. So that is why this is very important. When a terminal condition is missed or ignored, healthcare team continues to focus on aggressive curative treatments rather than switching to comfort care. So our above lady was not getting comfort care at the end, and she died in agony, and she had a very bad death. So prolonged pain and physical suffering. There are three things can be resulted from this: prolonged pain and physical suffering, emotional and psychological distress, institutional and logistic issues. So these you can see from that story: prolonged pain and physical suffering, inappropriate treatments. Patients are subjected to painful, invasive, and ultimately futile medical interventions. So she had central lines, so a lot of pricking, and she was connected to a lot of machines, and at the end she was giving inotropes, right? So a lot of painful invasive procedures. So these include aggressive cardiopulmonary resuscitation, painful injections, or unnecessary surgeries. So you need to understand, people who are close to death, they even request us to remove all the tubes and all the extra equipments which is connected to their body, including cannulas, catheters, NG tubes. So they want to be very peaceful. So a lot of my patients have requested those things when they coming closer to the terminal phase. So we have to agree with that. So see how badly we are treating these patients by inappropriately introducing these futile things. Overhydration and fluid overload. Administrating continuous intravenous fluid to a dying body often backfires. The failing organs cannot process the liquids, leading to distressing fluid accumulation in the lungs. Extreme swelling and severe breathing difficulties are the results. So actually what we are doing is, you might have heard a lot of family members are telling, can't you give at least a saline? Can't you give parenteral nutrition, because she's not eating, she didn't have a meal for several days. So these things, with a lot of communication skills, you need to convince the family members about nutrition. At this stage, the value of nutrition and fluid is not there so much. So those things has to be explained very tactfully. So inadequate pain management. Now, giving a lot of futile things at the same time, inadequate pain management and other symptom management. Because of the medical team is still trying to cure the patient, they may underdose or omit the strong continuous pain medications and sedatives needed to manage terminal pain and terminal agitation. So emotional and psychological distress, missed palliative support without a terminal diagnosis, specialized palliative care team are not brought into provide essential psychological and emotional counseling. Even though, I mean, in Sri Lanka we don't have specialized palliative care teams. What we do is whoever who learn about palliative care and who had some experience, we manage these things. But whatever, we are not allowed to do the palliative support because of this. So unprepared families, now loved ones remain under the false impression that the patient will recover because you are giving curative treatment. Why doctors are giving curative treatment? You want to cure the patient. If you can't cure the patient, you will not give curative treatment. So if the doctors and the health staff is giving curative treatment, that means the family members think patient will get cured. So they are not prepared for the patient's death. This lack of preparation lead to severe shock, confusion, and heightened grief when the patient abruptly passed away. So there are a lot of examples. I mean, I don't have time to tell all these things. There are a lot of examples we can give, especially for cirrhotic patients who admitted to wards and get the initial treatments. I mean, the family members or the patient will not get a good idea about what they are having, right? And they admit for the second time. Second time also, they don't know that this disease can lead to death. At one point, they are not prepared for these. So at one point, they die, one admission they might end up in a death. I mean, there are a lot of stories like that. So at that time, sometimes they die within 24 hours of the admission. So what you do is then you will order a inquest and a post-mortem. So unnecessarily, these patients are end up in postmortems also. I have many examples for these things. Unresolved final wishes. Now the patient is deprived of the opportunity to say their final goodbyes, resolve family matters, or document their explicit terminal life preferences. So, I mean, you are not allowing them to do these things by giving futile treatment and not telling the truth to the patient and the family members, right? Now, maybe earlier presentations, I have told you some patients during their last few days, they have seen their family members, I mean, the children getting married. So that sort of things are arranged, beautifully arranged in these terminal care situations and palliative care situation. I mean, we should not wait until the terminal situation, actually, at least end of life situation, we should arrange these things. So these things can happen. Distresses are common when we don't diagnose dying phase. So institutional and logistical issues. Dying in an intensive care unit. Instead of spending their final moments in a peaceful home setting or a dedicated hospice facility, the patient often dies in a noisy, highly clinical ICU environment with strangers, not with their loving ones. So imagine this, if it happens to us, how we feel, right? So the delayed hospice care. Now, if you don't diagnose dying, you don't give palliative care, either in home or hospice. So vital support system designed to assist families with terminal care logistics and bereavement counseling cannot be activated because we are not at that level. We are not accepting that this patient is dying. So how can we arrange these things? Benefit of correctly diagnosis of dying. Now, not diagnosing dying, there are a lot of disadvantages. But there are a lot of advantages, obviously, when we diagnose dying. Now, diagnosing a terminal illness provides a clarity that allows patients and their families to make informed, meaningful choices. It shifts the focus from curative treatments to maximizing quality of life, ensuring the patient's physical, emotional, and spiritual needs are met during their final chapter. Now, key benefits of the timely terminal diagnosis. One is symptom and pain management. Symptom and pain management, other symptoms and pain management allows medical team to focus on palliative care. So, utilizing exact medications and therapies to minimize suffering, manage pain, and reduce distress. Psychological readiness gives the patient and loved ones vital time to process emotions. So they can say goodbye, they can, whatever the relationships they need to build up, they can do that, right? Seek counseling, find closure, right? And have important conversations between the family members, between friends, right? We allow all these things to happen. Autonomy and care planning. So they should be able to decide things, empowers the patient to make their wishes known through advanced directives, ensuring their medical, legal, and financial affairs reflects their personal values. So let them finish all these things, right? So very recently, not more than 2 weeks back, I had a patient again with a pancreatic cancer, metastatic disease. He owned a private company, and his children and the wife are partners. So he wanted to do the legal workup before he dies. So immediately, because I told them at one point, because he had liver mets and liver failure, initial phase of liver failure. So I told him that this patient will end up in hepatic coma. So at that time, he will not have the capacity to take decisions. So before that, he should finish all the legal work or other things. So they have done that. So autonomy and care plan. So resource allocation now connects families with specialized hospice care services, which provide dedicated nursing support, respite for caregivers, and grief counseling. All these things can be planned and allocated and arranged. So meaningful time. Now, whatever the remaining time enables families to prioritize spending quality time together, fulfilling final wishes, and ensuring the patient is surrounded by comfort in their preferred setting. Now, these days, I saw in the Facebook, there's a small joke. A doctor is telling the patient, "I have a good news and a bad news for you." So the patient asks, "Doctor, tell me the good news. You have 24 hours to live." Then he was upset. He asks, "Okay, doctor, what is the bad news?" Sorry, actually, I was planning to tell this yesterday that you have 24 hours to live, but I forgot to tell you that yesterday. So that was the bad news. So you can imagine that is a joke actually, but in reality, that is what happening. In reality, that is what happening, right? We are not giving enough time for the patients and the family members to plan their remaining period of the disease trajectory. Now, ethical principles in terminal care. Now, ethical principles in terminal care guide healthcare providers to relieve suffering, uphold dignity, and respect patients' wishes during the terminal life. So, this is actually a guide. It guides the clinical staff, healthcare staff. So, these guidelines have 4 components: autonomy, beneficence, non-maleficence, justice. Now, this prevent harm and ensure compassionate, equitable treatment for the patient. Now, the 4 core pillars. Autonomy. Now, this respect a patient's right to make informed personal decision about their care. Now, informed personal decision means patients should be informed what has happened up to now and what is happening now at the moment and what is going to happen in the future. We have, as clinicians, we have to inform them. We have to give them all the information relevant to his or her issue. the disease, right? And then we are empowering the patient to take their personal decisions. Without knowing what is happening, they can't take the decision. That is very important. You can't just ask the patient what is your preferences and what are your preferences. You have to give the information. You have to empower the person. Now, including refusing life-sustaining treatments. Now, how can a patient decide not having life-sustaining treatment if he doesn't know what is going on? Utilizing advanced directives, right? So he can tell what should be done, and appointing a surrogate. So these things can be done if he knows what is happening. So autonomy, we have to respect autonomy with informed personal decision about their care, right? So they should be empowered to take decisions about their management. Beneficence obligates providers to act in the patient's best interest. In terminal care, this means prioritizing pain management, comfort, and emotional well-being over curative effects. Right? So always what we do is what is best for the patient. What is best for the patient. Even the family members are requesting something which is not good for the patient. As clinician, we can avoid those things, right? But avoiding is very, I mean, you have to do it in a very careful way. You have to use your communication skills and educate them and try to make them understand why you are not providing these things, because it causes bad things to the patient. So we do only the good things for the patient. Non-maleficence, the duty to do no harm. We are not going to do any harm to the patient by whatever the things we are doing. Providers must carefully weigh the burden of aggressive, invasive treatments against their actual benefits, avoiding unnecessary suffering. So, inappropriately giving futile treatment is actually violating medical ethics, right? So, the justice, the last one, ensures fair and equitable access to palliative and terminal care resources, regardless of patient's background or socioeconomic status. So at the moment, majority of our patients are not getting this, unfortunately. Justice is not happening. Now, key ethical concepts in practice: withholding or withdrawing treatment. Now, ethically permissible when life-sustaining interventions are deemed futile or contrary to the patient's goal. So, if life-sustaining treatments are not going to give any benefit to the patient, and if it is not fit into the patient's advanced directives, so you can withhold them or we can withdraw them, right? So the goal is to allow a natural death without prolonging the dying process. Now, you can prolong the life by few days or few hours by connecting to a patient to a ventilator, intubate the patient if patient goes into respiratory failure. But what you are doing is you prolong the suffering, right? So if patient was educated about this before he come to this stage, so they can decide whether I should connect to a whether I should be intubated or not, whether I should be given cardiac massage or not. If I know that it is merely a torturing for me, I can tell, please don't give cardiac massage to me, and please don't give inotropes or medications to keep my heart pumping blood for additional few days, because that is not quality life, right? So withholding and withdrawing treatments, if they are appropriate, because they do not do any good to the patient, and sometimes they do harm to the patient, right? So, and if it is against the patient autonomy, patient's wishes, so we can stop them. And sometimes you have to stage by stage, step by step, withhold certain medications. Usually you stop, first to stop is nutritional supplements, vitamins, minerals, those things. Then the second thing, you don't withhold everything at once. You step by step withhold things. Maybe today you withhold nutritional supplements, multivitamins, and minerals. The next day you can withhold dyslipidemia medications like statins. Maybe next day the diabetic medications. Likewise, you withhold life prolonging medication next stepwise, and then you continue the comfort medications, pain medication, medication for agitation, medications to dry up the secretions. So all these medications you continue because those are controlling the patient's symptoms and improving the quality of life. Now the principles of double effect. Now stated that an action intended to have a good effect. Now this comes in opioid medications, right? The good effect is administration high dose morphine to relieve terminal pain, and is ethically permissible even if it has foreseen but unintended bad effects, hastening death. Now this is actually a myth, clinical myth. You might have heard some clinicians are telling it's okay, give some morphine to control the pain, even though, I mean, he is anyway dying now. Let him have some morphine dose. That doesn't, I mean, that is okay, even it hastens the death. So that is a myth. That is a wrong concept, right? That is a wrong concept. If you are using appropriate opioid doses, that will never hasten the death. So this is a clinical myth. So that is called principle of double effect. You are doing a good thing and you are accepting the bad thing. Wrong. That is wrong. If you give correct appropriate doses of opioid, patient will never get a bad effect like death due to opioids if you are carefully titrating the dose. So you need to remember that. You might hear these things in your clinical setup. Palliative sedation, the use of medication to induce unconsciousness in patients with intractable severe symptoms when all other interventions fail. During the final days of life, the intention is strictly to relieve suffering, not to cause death. Now, palliative sedation, I have used once or twice. I can remember one patient to get consent from the children because the mother didn't have the capacity to decide. The son was avoiding me when I was talking because initially I told I need to discuss about palliative sedation. That was the mistake I did. I should not have told palliative sedation. I should have told the son that I need to discuss an important thing. Please come and meet me. Instead of that, I told palliative sedation. So son was avoiding me for 1 or 2 days, thinking that this is something like euthanasia, right? Actually, that patient had vesico-urethral fistula, vesico-vaginal fistula, and enterovesical and enterovaginal fistula. So she was passing stools via urine. She was passing stools via the vagina. So she was in extreme pain. Even morphine infusions cannot relieve that pain. You can imagine how bad was that. So the solution was actually palliative sedation because there were no other option. I mean, we cannot divert the bowel by doing colostomy bag insertion because she was not fit for any surgical intervention. She was closer to the terminal phase at that time. So actually she was in terminal phase. So at the end, I have arranged the terminal sedation with morphine and midazolam. So after understanding what I'm going to do, the son accepted that and he apologized me that for avoiding me. So ultimately the patient had a peaceful end. So that is palliative sedation, and you call it palliative sedation or terminal sedation. Both terminologies are okay. Now, compassion in terminal care. Now, compassion in terminal care is the active response to patients' physical, emotional, and spiritual suffering. It goes beyond basic symptom management to prioritize dignity, patient autonomy, and holistic support for both the individual and their loved ones through the terminal phase journey. So, key pillars of compassionate terminal care: symptom management. You need competence. Effective relief of pain, breathlessness, and anxiety is the cornerstone of compassion. Utilizing expert medical knowledge to keep a patient comfortable, prevent unnecessary physical suffering. Now, the other one is active listening and empathy. Now, this is something we don't have much. This is something we don't practice. Allowing patient to express fears, regrets, or their desire for legacy without judgment. Understanding who the patient was before their diagnosis ensure they are treated as a person, not just as a condition, not as a pancreatic cancer, not as a cirrhotic liver, or not as a motor neuron disease. So we should consider them as a person, right? So we should allow them to express their views, right? So the same patient who had pancreatic cancer with multiple metastases, who was a businessman, when I was doing the family discussion, I understood that the main contributor for care was actually not the wife, it was the sister. And she was telling that my brother is talking very high about things. He was talking about millions of money. I have asked him to stop this, but he's not doing that. So I asked her whether he liked to do that, whether he was doing the same thing when he was well. Yes, he was always like that. Then I advise her not to stop that. Let him be like he was. Let him talk about that. He is not talking to anyone else, no, he is talking to the family members. He might talk to me about those things, so I can patiently listen to him, right? So let him talk to me. He enjoy that. He enjoy about his success things, about his business. So let him talk about that. So he was talking about that before he became, one day before he became, he got his hepatic coma condition. So that is the last day of he did that. So we should allow him to do that. So active listening with empathy, right? With empathy. The family support, extending compassion to family members and caregivers by addressing their distress, providing clear communication and offering bereavement resources, right? So you need to listen to the family members, caregivers also addressing their distresses. They have a lot of distresses. They have a lot of issues. Actually, the patient whom I was talking about with pancreatic cancer with metastasis, his wife having autoimmune disease, which is also not curable, right? So we have to listen to their issues also, right? So we have to communicate things very clearly. Don't tell that, don't worry, nothing is going to happen. That sort of vague things we should not use in palliative care, right? We have to be very specific and very clear. And the bereavement resources, we have to do a lot of things. When a patient dies, if he dies at home, what are the things they should do? If he dies in the hospice or hospital, confirmation of death, the MBBS qualified doctor will do that. Then if he is in at home, then the GS has to give a certificate. Then the registrar, if it is in the hospital, from the death, hospital to the registrar. So all these things, the contact numbers, addresses, how to do these things. So all these things we should educate the bereavement phase how to do these things. If there are help systems, transportation systems, we have to introduce them. Now, respect for autonomy, honoring individual preferences regarding where care is provided. Example, at home versus hospice facility, who makes decisions on their behalf. Now, if most of the time during the terminal phase, patient may not be capable of giving decisions. So before he become to that situation, they should have a surrogate to make decisions. So who make decisions on their behalf and managing terminal life wishes. So during the terminal phase, what are the wishes that patient wanted to fulfill? All these things we need to respect. Sometimes these things may not be logical for us, but even we should try to try to help them to accomplish them. We should help them to fulfill these things. Challenges to providing compassionate care. The heavy emotional toll of witnessing repeated suffering can sometimes lead to compassion fatigue or burnouts among healthcare professionals and family caregivers. This is something all of us are forgetting. We are not concerning about the caregivers and the healthcare workers. So they get fatigue, they get burnouts because every day they are living with these situations. They don't have a rest. So systemic pressure such as work overload or limited resources can also obstruct the delivery of this vital care. Organizations and support systems strive to address this by focusing on providing self-care and resilience. So the healthcare team should be able to identify their colleagues, whether they are going into burnouts, whether they are in fatigue. So they should give them some relief, right? So these are very important in terminal care. Compassion in terminal care requires a holistic, patient-centered approach focused on comfort, dignity, and symptom relief. It blends pharmacological interventions with emotional and spiritual support to enhance the quality of life for patients and their loved ones. Physical care, holistic, and psychosocial care are the components. Now, what are we going to do during terminal care? Terminal pain management, prioritizing regular around the clock administration of analgesics like opioids rather than waiting for pain to peak. So the gold standard therapy is morphine infusions. So there are other medications also like fentanyl infusions. So usually the ideal route is subcut route, right? So we should use that because putting IV cannula is also painful. So subcut cannula is the perfect route for terminal pain management with morphine infusions. Terminal agitation management. First, identify and treat reversible causes for agitation like urinary retention, uncontrolled pain. So if pharmacological management is needed, medications such as Medislam, haloperidol are typically used. I usually use Medislam infusions. Terminal secretion management, manage death rattles by repositioning the patient on their side to facilitate natural drainage. Pharmacological options like hyoscine butyl bromide or glycopyrronium can reduce fluid production. So what I use is hyoscine butyl bromide. Those medications can be used via subcutaneous route. So suctioning should be avoided as it often causes deep suctioning should be avoided because it causes a lot of discomfort to the patient. Superficial suction may be okay if there are a lot of secretions because even these medications may not be dry up already established secretions. So oral and skin care, which is very important, keep the mouth moist using ice chips, swabs, or lip balm, prevent pressure injuries, bed sores with frequent repositioning, pressure relieving mattresses or barrier cream. So bowel and bladder care, monitor for urinary retention, constipation, and manage these by catheterization or administration scheduled laxatives. Now, if patient is in a coma, you can't give oral medication, then you might have to put a enema, whichever way it is appropriate. Manage incontinence strictly for skin integrity and hygiene, right? You don't put catheters always. If you can clean, manage this, okay. Otherwise, to keep the skin integrity and hygiene, you put a urinary catheter. But if patient refuses, then you have to clean more frequently. Terminal care, holistic and psychosocial care. Psychological care, validate the patient's feeling and provide a calming presence. Monitor for delirium and address any underlying distress using comfort measures, familiar voices, and low stimulus environment. So always tell the family members to touch the patient gently. You can do gentle massaging and tell their loving ones who is in the terminal phase that your presence, that is the most important thing. Don't tell the patient that don't worry, you are okay, nothing is going to happen. Don't tell those words. Patient will get agitated because patient knows that patient is dying. So if he thinks that his or her loving ones can't understand what is happening, then he get agitated. Spiritual care. What are the patient's faith, values, and traditions? Offer pastoral care or quiet moments for reflection according to their personal wishes, which can help alleviate existing anxiety. So you have to do this appropriately, whatever the patient wishes or the family members. Social care. Support the family by keeping them involved in hands-on care if they wish. If they wish, they can allow them to, cleaning, all these things, morning care, the evening care, all these cares, the family members can involve, ask them to help, because that gives them some satisfaction. Address their grief, provide clear communication about what is to expect during the dying process, and offer bereavement support. Advanced technology in terminal care. Now, this is a new thing. Advanced technology in terminal and palliative care focus on maximizing comfort, managing symptoms, and maintaining patients' quality of life and dignity. So, modern solutions utilize remote monitoring, artificial intelligence, and virtual reality to support terminal care in both hospice and home settings. Now, key technological applications. So I did a Google search about these things. Actually, certain countries, even in Sri Lanka, what they are mentioning is certain NGOs or certain organizations are using some of these things. Remote patient monitoring, RPM, um, variable devices and smart biosensors continuously track vital signs, heart rate, oxygen levels, pain indicator. Now, actually, in terminal situation, these things are not very important, but in end-of-life situation, these are valuable. And instantly alert clinical teams to changes allows for rapid, non-invasive adjustment in medications. So RPM, these things are helpful. Some countries they are using. I saw in one place that even in Sri Lanka some are using, but I don't know what to what extent. Telehealth and virtual consultations, video conferencing platforms enable terminally ill patients, especially those in rural areas or at home, to receive continuous 24/7 specialist support, minimizing stressful hospital visits. Actually, once we did this when we were doing the pilot project for injectable morphine, feasibility test for using injectable morphine, subcutaneous morphine in the community level, which we did it as requested by the Ministry of Health in Kandy. So I should mention here that the team, Kandy team, the RDHS at that time, Dr. Talagala and his team visited personally to the patient's home, and they were getting a video call for me to see the patient and advise them on what to do. So actually that was telehealth, virtual consultation. So that is very helpful. Far away from Colombo, so we gave our opinion. And even the same patient with pancreatic cancer patient with metastatic disease who was dying, just before dying, the family members knew that I have explained them what will happen. The breathing pattern will change. At that time, they got a little bit agitated and they wanted to know whether their patient is dying. So they informed the nurses that they wanted me to check this. So they sent me a video clip because I didn't want to get a video call because that was in the middle of the night. So I asked them to send a video clip, WhatsApp me. So that was chain stroke breathing, that is gasping. So I told the family members, please be with him, don't leave the patient. The sister, the wife, and 2 daughters to be with him at this moment because we are having very limited time. So virtual reality therapeutics. So VR headsets acts as pharmacological interventions, immersing patients in soothing natural environments or guided mindfulness, which reduce anxiety, discomfort, and pain. Actually, these things can be used as complementary therapies, not only for end-of-life patients or terminally ill patients, even for curative patients, you can use this as a complementary therapy, virtual reality therapeutics. So artificial intelligence, AI is increasingly used for predictive analytics to monitor disease progression, anticipate symptom trends, and personalize pain management plans. Actually, this was done in several countries, developed countries. So mobile health apps, digital platforms allow patients and their family caregivers to log symptoms, manage medication schedules, and communicate directly with healthcare providers in real time. At that time, at the same time. So these things are available as, in certain countries. Robotics and smart homes, companion and assistive robots help patients maintain a degree of independence by assisting with mobility, while smart home automation, voice activated assistance, enables remote communication and environmental control. These things are done in Spain, Singapore, Japan, and Canada. They have tried this. Benefits and challenges of these new technologies. Transformative benefits include earlier symptom interventions, reduced caregiver burnouts, strong emotional and social connections. Challenges. Successful implementation relies on overcoming barriers such as technology cost, privacy concerns, and varying levels of digital literacy among older population, because most of these terminal cares are involving older population. So these are the now at last, if patient requested a terminal discharge, patient only wishes to go home for the last time. So we need to arrange this as a, considering this as an emergency. Terminal discharge is you are discharging the patient wants to die at home in their home. So you need to arrange everything, educate the family members, give medications. So you need to understand in Sri Lanka, we cannot do this in a perfect way because we cannot give injectable morphine, injectable midazolam to be used at home. So you see um, how low we are doing this care, right? So we need to improve these things. If patient requested that they need to go home, we have to arrange it as soon as possible, considering this as an emergency, right? Emergency. So we need to educate the family members how to give the morphine injections, how to care them, pain management, agitation, terminal secretion, skin care, oral care, bowel bladder care, emotional care, social things, spiritual things. All these advice we need to give. At the same time, we need to arrange the home care community team to visit this patient frequently and immediately when they reach home. So we are developing. We are actually at the level developing level. At this stage, we have a community nurse. So that nurse responsibility is to visit this patient. So we out to give those who are to live the life the same care and attention that we give to those who enter the life, the newborn. The same care we have to give for the person who is leaving. Yuan Steinwert. So we need to understand this. It is little short of a tragedy. It is little short of a tragedy if someone has high quality palliative care. That means general palliative care and end of life care. And when they become terminal over a period of many months, only to die in poor controlled suffering of body or mind, watched over by relatives who had understandably expected something better. Because if they have observed good palliative care at the initial stage, if they don't get it at the latter part, then that will be a disaster. Indeed, some might argue that ensuring a comfortable and dignified terminal phase is one of the principal reasons for the patients being referred to a palliative care team. Okay, so you know that that's the last slide. You know that Sri Lanka is in the palliative care setting, Sri Lanka is in level 3B. You know, no palliative care is group 1, and isolated palliative care, if you are implementing palliative care, trying to implement palliative care is group 2, and we are at group 3A, that is isolated palliative care. India is in level 3B. The developed countries are in 4A and 4B. So we have a long way to go. So telling that, I would like to conclude my session. I have taken 6 minutes more. Okay, thank you. If you have any
Thank you
questions,
very
you can.
much. Yeah, thank you very much, Dr. Gunadilaka. I think it's an excellent presentation. Very good with the lot of practical experience and the applications. I think you have really done a marvelous job. So I think it's open for, I think your last slide is very beautiful, very handsome. And this is over to you. I know the time is past, but we can really open for the few, if you have any questions to be things. Anyone wants to ask any question from Dr. Gunadilaka?
Thank you for the very excellent presentation. So I feel like now if we are to be successful, on one hand, clinicians, they have to practice. At the same time, public awareness should be raised regarding this. What do you think, Dr. Sharma?
Yeah, that is actually a very, very important thing, because with the bad experience in the past, a lot of people think that when we talk about palliative care, they think that is the end. That is the end of the patient. So most of these patients, family members, they are reluctant to accept palliative care. So they should be educated about palliative care. Otherwise, even though we train the clinicians and the healthcare staff, that our task is not going to complete. So it is very important, all the aspects, all the layers who are responsible for this has to be educated. The one important layer is the community. So the community involvements and the patients, their family members, all of them has to be educated very well. Otherwise, this is not going to give good results, because the community should accept this. To accept this, they need to know how valuable is this. They should see the outcome of this, good outcome of this. So definitely, I mean, it is our responsibility to do that. I think individually, every clinician, every healthcare staff member can do their part. You know, whatever in the Facebook, any medias, newspapers, YouTube, or whatever the resource, they should use and do some contribution. This is not for others. This is also for yourself. One day we might need palliative care. So if the country doesn't have a good palliative care, we will have to die in agony. I have seen many doctors, many directors in health sector, higher level people dying in agony. So at least think about ourselves, have a little bit of selfishness, and try to improve this palliative care.
I think excellent answer. I think now Dr. Thalagal is there, as he had done a good job in connecting the patients. So we should really, Dr. Thalagal, you should really connect them more and more especially with our GPMOs and with specialists like Dr. Gunadilaka.
Exactly, yes.
You have now more opportunity. You are now director. I think you should really think about that as our national level now.
I don't know whether Dr. Sampath is there. Sampath Kondasinghe.
Thank you very much for the great presentation, Dr. Gunadilaka. Yes, so I'm here.
Yes.
Can I ask you one question, Dr. Sampath? Because now in the ministry level also we are facing a lot of difficulties in there are a lot of barriers in developing palliative care here. So one thing is now deciding when we have a patient with pain to decide this whether this patient need opioids or not. In our culture we think that is a specialist decision. My opinion is that is not so. So what is the situation there in Australia? If you create a doctor with MBBS, whether that doctor is capable to decide whether this patient should need opioids or not to relieve the pain, can that medical officer whether this medical officer has the capacity to decide? Can you please tell us what is the situation there?
Yeah, before giving the answer, I do remember when I was studying in Colombo Medical School 25 years ago, they didn't want the specialist to give morphine when people come with chest pain for myocardial infarction. How come now situation has happened to the level that when our most needed cancer patients need the painkillers, only specialists can provide it. That's the counter argument, I suppose, here. I suppose any of these medical officers won't be hesitant if the patient comes with extreme chest pain with myocardial infarction to give a dose of morphine. And they all know we are not going to kill that patient by giving morphine dose in the myocardial infarction. And how come when the cancer patient has a even more severe pain, there are barriers to give the medications. To answer your exact question, Sharma, what it is here where I practice, every doctor can give opioids. There are restrictions for opioids, for specialist opioids like methadone, but standard opioids, or morphine, oxycodone, hydromorphone, all the other standard opioids or fentanyl, there are no restrictions for general doctors. In fact, like last 15 years, my job, other job is in University of Western Australia. I teach the final year medical students. So every doctor basically, when they graduate with the MBBS or at that stage, they are ready to prescribe opioid. That is the truth for every medical school here in Australia. There is no exception here. Especially, I mean, I do not know how there might be the legality in Sri Lanka, which I do not know, but at the moment, here in Australia, we do not, doctors don't need extra certification or anything, but they do get teaching in palliative care in final year in every medical school.
Right. Thank you, Sampath. And the other question is, because these are very important in our settings, oral opioids versus injectable opioids. So whatever the route, the drug is same, but here there is a fear about injectable morphine, because that is the reason we are not allowed to use it outside the hospital settings. We are trying to use it. So what is the, I mean, is there any, is this fear is justifiable? Whether there is any difference between oral opioids and injectable opioids?
Yeah, if you talk about pharmacology, the bioavailability of the oral opioids is 1/3. So, for example, if you give 10 milligrams of oral morphine and 3 milligrams of injectable morphine, that's the same dose basically. So if you're giving an equivalent dose, there is no concern. I suppose some people have a concern about the injectable opioids when the peak concentration happens. So if you inject intravenously, your peak concentration happens around 5 to 10 minutes time. If you give subcutaneously, it will happen around 10 minutes time. If you give orally, the peak concentration or peak effect happens around 30-minute time. So that But regardless of that, if you give an equivalent dose, your peak level will be the same basically. So there is no concern if you give a equivalent dose, which is like a 10 milligrams of injectable will be the 30 milligrams of oral basically. 1/3 is the bioavailability. So if you give the equivalent dose, there are no differences in practice basically.
Thank you, Sampath. Because those are the concerns, actually preventing the use of injectable morphine in the community. So certain fears are there. So that those are the things we are trying to overcome, which is very difficult here in Sri Lanka. Thank you so much.
I think, Dr. Gunadilaka, you did the excellent job, and I think it's a lot of interactions and with the practical experience. Thank you very much for your all the experience as well as your presentation. Hope to see you in our annual sessions with the more and more kind of new theories and the new knowledge and the new practice. Thank you very much once again.
Thank you very much.